Can you hear me properly?
Yeah, we can hear you.
Okay. So today's topic of discussion on nutrition is on enteral supplements, and especially for preterm babies.
Srinivasa, just a minute. Can you share your screen again?
Oh,
We are
it's
unable to
shared.
see your screen.
Just a second. Can you see now?
Yeah, we are able to see.
So today's topic of discussion is on enteral supplements for preterm units. I'll be concentrating more on VLBW babies or less than 1.8 kg babies. More than 8 kgs, 1.8 kgs, I'm not discussing today. Okay. So today's objectives of study presentation is just to discuss about the enteral nutrition supplements requirement during an ICU stay. What are the things that is required in addition to breast milk or formula milk or fortified milk for the baby, and also following discharge of the baby from the NICU, what should be the baby on? Whether additional supplements that the baby should be on following discharge. So we'll start with an index case. We have an X26 plus 3 weeker, which is 800-gram neonate. Today is 25 days old and had achieved full feeds. Birth weight, baby's weight, today's weight is around 710 grams, and on 13 ml of feeds every 13 ml of feeds, either EBM or donor the baby is taking. And as of now, the baby is not having any IV cannula and no other supplements. Evaluation for poor weight gain in this child, even at 25 days, the baby has not gained weight. So the baby was evaluated. Hemoglobin was fine. Sodium, CRP, gases, etc. were all fine actually for poor weight gain. And the question comes here is, what are the reasons for this poor weight gain in this child? And does this poor weight gain have any neurological impact in this child? And what are the ways to correct this poor weight gain in this baby? We ask questions like this actually. So we need to answer to answer these questions. We need to know what do we mean by extrauterine growth retardation, EUGR, what is called as. It is defined as preterm baby weight less than 10 percentile at discharge home. So there are many studies that has been done, and few databases also reveal the percentages of babies which are having EUGR, that is less than 10 centile at the time of discharge. Clark et al. Reported around 28% of the babies who had EUGR. Dusick et al. Reported around 99% of the babies with EUGR. Relatively, these babies had a lower birth weight when compared to that of Clark et al. And from the Western Australian database, less than 28-week babies had around 50% of incidence of EUGR in these children. And in that, 18% of the babies were IUGR, also intrauterine growth retarded, at the time of birth. So when you see this picture, you can realize that the EUGR or extrauterine growth retardation is related to the gestation of the baby. The lesser the gestation, the incidence of EUGR is very high. Here you can see that the incidence of EUGR in 23 weeks 23 weeks gestation babies is somewhere around 65 to 75%, whereas when you go to 34 weeks, it is somewhere between 0 to 49%. Similarly, with the in related to the if the babies with the lower length actually, more than 90% of the babies at 23 weeks of gestation, babies will be IUGR in relation to 33, 34 weeks gestation babies, which are somewhere between 0 to 30%. A similar picture is seen in head circumferences, but relatively the percentages are lower. So, why is this EUGR prevention in NICU is important. It is known that EUGR is associated with long-term low growth as well as long-term cognitive impairment. The babies are evaluated at 18 to 24 months. Most babies had issues with cognitive impairment, and some babies even there are reports of motor impairment also in the studies. Electron et al. Reported that there is a dose-dependent association between early postnatal growth and neurodevelopmental outcomes at 18 to 22 months. You can see in this picture, you can see that mental developmental index, if the baby is gaining at around 12 gram per kg per day in the NICU, the MDI for the child will be less than 70% in 40% of the patients. In comparison to the babies who are grown at 21 grams per kg per day, whose MDI is less than 17, just 20% of the babies. Similarly, neurodevelopmental impairment, you can see that babies who are growing at 12 grams per kg per day have around 50% of the babies have neurodevelopmental impairment, whereas babies who are grown in at 21 grams per day per kg per day have a neurodevelopmental impairment in around 25% of the patients. So why this EUGR happens actually? The reason we see that based upon intrauterine accretion rates, the energy and protein has been given by various bodies actually. Various societies have been given. The latest consensus was in 2014, but prior to that, it was in 2010 by Epsilon. Says that the energy requirement for a baby is somewhere around 110 to 135, and the protein requirement is for babies less than 1 kg is between 4 to 4.5 and per kg per grams per kg per day, and for babies more than 1 kg it is 3.5 to 4.5 grams per kg. So there is relatively high requirements for these babies. So there is relatively high requirements for the babies. There is inadequate intake of protein, energy, and micronutrients in this preterm units. And protein is considered to be the limiting factor in these babies for growth. So this is as per the ESPGHAN recommendations. When you see that the protein is 4 to 4.5 grams and 3.5 to 4 grams. But when you compare to a human milk actually at 180 ml per kg, you see that most of the components are deficient. For example, protein is just 1.98 gram per kg per day, and most of the multivitamins, calcium, phosphorus, iron are all deficient. As a result of this, the baby's growth is severely impaired. So how to prevent this extrauterine growth retardation? One way is to supplement or give multinutrient supplementation. It can be protein, minerals, and or vitamins. So fortification or multinutrient supplementation can be done in the form of either monocomponent fortifier or by using multi-component fortifier. So now you decide to add fortifier in our index case because you know that baby's growth is important. So the next subsequent questions that we have is there any evidence for its use? If so, which one to use, and when to use and how to use? What can be done in Indian setting? What should be done if you don't have anyone? So let's move on to the monocomponent fortifier. Cochrane has viewed many of the monocomponent fortifiers, especially carbohydrates, fat fortification, as well as protein fortification individually. For carbohydrate fortification, only one study is there on prebiotic carbohydrate supplementation. It is not well studied and there is low quality of evidence. It had shown a good weight gain, but there was no difference in neck or feeding intolerance, and there was no outside the hospital outcome studies like long-term neurological outcomes was not there. It was updated in 2018. Similarly, regarding the fat fortification, there is one randomized controlled trial which included around 14 patients, and they had used both MCT as well as long chain unsaturated acids. And they did not find any difference fortifying babies with fat in regards to length gain or head circumference. And there was, since it was a small size sample and with low precision of index, nobody recommends doing fat fortification. But definitely there are some observational studies on MCT oil, but randomized controlled trials are lacking. Monocomponent for third one is the protein supplementation. There are totally 6 randomized controlled trials with 204 preterm neonates, which had evaluated for protein supplementation. Protein supplementation, usually we don't have a protein supplement as such here, but in abroad they use this Premi protein supplement actually. And this had shown significant weight increase, length increase, and as well as head circumference increase in these children. This is a simplified forest plot for carpentry. So small sample size, low precision, and very low quality of evidence. No data on the outcomes after discharge, and no studies in low resource settings. Even though protein has shown to be beneficial, but it lacks in other components. So because of that, multi-component fortifiers are used. And since there is multi-component fortifiers are they started using it. Since multi-component fortifier have been started to use, they have stopped using the protein supplements individually. So based on the type of milk, origin of milk, multi-component fortifiers can be classified into: one is bovine milk fortifier, one is human milk derived fortifiers, and recently they have started using donkey milk fortifier. There is one randomized control trial which I'll be describing. So this is regarding the bovine milk derived multi-nutrient fortifiers. Uh, there are around 14 randomized control trials with more than 1,071 population, and in which has evaluated on weight, length, and head circumference. And multi-nutrient fortification using bovine milk has shown to increase significantly the weight, length, and head circumference. These are regarding the short-term outcomes. So when you compare with the long-term outcomes like mental developmental index, psychomotor, uh, psychomotor developmental index, and mental developmental index, there was no difference in the outcomes. So the explanation for this, the reason why there was no difference was that there was only one randomized control trial which evaluated it with 245 cases. And there were, when we retrospectively studied that article, I found that the fortification process was entirely different, and the amount of protein and calorie that they were giving at that time was not sufficient. And in addition to that, one more important outcome is that there was no difference in the necrotizing enterocolitis between the two groups. Now, coming to human milk derived fortifiers, there is a lot of craze on human milk fortifiers that has been seen now. So recently, one systematic review done by Anantan et al. From a team from Australia, they have found that the definitive neck incidence was decreased significantly when you are using human milk derived fortifiers. They included around 4 randomized controlled trials with 334 patients. But to my surprise, when I went when I went through the Cochrane, which was reviewed in the 2019-18, they included only one study. And when I evaluated that, I saw that in these randomized controlled trials, other three randomized control trials, what they have done is the mother's milk in the one control group was supplemented with formula instead of donor milk. The intervention group was use in the intervention group, they used mother's milk, donor milk, and human milk derived fortifiers. In the control group, they had used mother's milk, formula milk, and donor milk, and bovine milk fortifiers. As a result of this, the neck incidence was quite high in these babies. So Cochrane did not included only one study, which was published by Connor O et al., which had not shown any difference in the incidence of neck. So the issues with human milk derived fortifiers is that we have limited efficacy. Only one study done by Optimum trial, in which they did not find any difference in the incidence of neck. Regarding the safety data, we don't know the metabolic effects of these human milk fortifiers, because once the milk fortifier is processed, actually they add some minerals and extra vitamins into that fortifiers, and then they distribute it. So we don't know what would be the metabolic effects. In addition to that, we don't know how much of fat or lean mass deposition that human milk fortifiers can uh, cause with that. Third thing is that there is ethical concerns about the origin of milk. So in a place like India, if you start using milk fortifiers, if it becomes commercialized, um, many mothers will be motivated to sell the breast milk for money's sake. And there are profit and non-profit organizations which are selling these human milk fortifiers. Human milk fortifiers should be done by non-profit organizations than a business model. Next is there should be some regulating body for these milk fortifiers, which, even though there are some in India, but stringent guidelines has to be made for the people who are doing this human milk fortifiers. And it's on top of it, it's extremely expensive, and it is too early to draw conclusions. Third is the downstream milk fortifier. This has been used in one randomized controlled trial, which is published in January 2019. And this was just a feasibility study, and they found that it is suitable for feeding preterm. And compared to bovine counterpart, they compared with bovine milk fortifiers, it improved feeding tolerance. So after knowing the types of fortifiers, let us move on to types based upon the form. Fortifiers can be either used as a powder or liquid. The disadvantages of powdered milk fortifiers is in India, most of the centers use uh, powdered fortifiers. There is increased risk of infection. As per the CDC guidelines, there is more risk of infection in powdered fortifiers, especially with the chronobacterial infection and enterobacterial infection. There is risk of intestinal plug formation, especially in post-surgical cases. When you are treating necrotizing enterocolitis and the baby recovers from neck, and most babies, when you start fortification in these children, they end up having acute intestinal obstruction features because of this intestinal calculi. And third important problem that we saw from powder fortifier is that there was a difficulty in mixing. So in order to combat this, so in US, they started the first acidified liquid like acidified liquid milk fortifiers. So they did a study in somewhere around 2013 or 14 with acidified liquid humidifier. The acidification was done in order to prevent the risk of infection. But when they compared with powdered human milk fortifier, they found that the babies had more acidosis, less weight gain, and it was of even though the osmolarity of this fluid was around 326 or 327. And then, because of this, they stopped using the acidified uh, fortifiers, and then they started using non-acidified fortifiers, which showed better weight gain and length gain, as well as better lipid composition. Other problem with liquid fortifiers is that it displaces a lot of volume of breast milk in the baby diet. So if for 25 ml of fortification, you have to use around 5 ml of 5 ml of fortifier. So it means to say that you are adding it to just 20 ml of breast milk. So you're dividing baby with around 5 ml of breast milk because of this fortification. So there are few fortifiers which are available not in India but outside India. The Similac use non-acidified liquid human fortifiers, and Enfamil had started with acidified liquid humidifiers. And in Canada, they did a study with concentrated preterm formulas, and they used this concentrated preterm formulas as liquid fortifiers. And this was specially used in babies who, for post-surgical babies or babies who had feed intolerance with powdered milk fortifiers. And they did find benefit in these children. So, yes, since it is not available in India, we may not be using this human milk fortifier shortly. But in future, maybe when it comes, I think we can think of using it. So if you want to use it in a child, then non-acidified liquid humidifier is considered as a better way of using it. Right now, only in USA, and we need more RCTs, systematic review and meta-analysis to find the long-term outcomes as well as other outcome data for this. So what are the fortifiers that are available in India? We have Lactodex, which has been used for many years in India. We have Prenan HMF, human milk fortifier. We have Hijam HMF. One human milk derived fortifier, that is Neolacta MMF, which was available in both powder as well as liquid format. But now the liquid form is not available in the market. Only the powder form is seen. So what are the strategies for human milk fortification? We have standard fortification, we have targeted fortification, and we have adjustable fortification. And targeted and adjustable fortification is titrated towards for the needs of the patient, and that's why it is called as individual fortification. Whereas standard fortification is based upon the company's recommendation. So why do we need different strategies for fortification? You can see here the protein concentration of preterm milk is widely variable. Actually, the concentration may be from 1.7 gram per deciliter to somewhere around 1 gram per deciliter on same day of life. Actually, and when you so with such variability in protein concentration, and in addition to that, you can see that the concentration of protein also decreases as the days prolong. Actually, by 28 to 42 days, the breast milk concentration in preterm becomes more or less like term infants. But initial 42 days is the way, or the initial 7 weeks is the time when most of the times we require fortification in a baby. So, because what the standard fortification recommends, that is what most commonly used in most parts of the world. Here, what happens is industry thinks that the fortification industry thinks that the breast milk concentration, protein concentration is 1.5, which can be more or less in a preterm maybe, and it depends upon what is the day of life and other things. And if and they recommend an intake of 3.5 to 4.4 gram per kg per day. What happens is if you fortify early with the industry recommended or standard fortification early, where the concentration of breast milk is high, what happens is we are going to give more protein for the child. In the later stages, we are going to give less protein because the industry standard assumes it is 1.5 gram per deciliter, but actually the baby will be having somewhere around 1.1 or 1.2 gram per deciliter of protein. So because of that, they got adjustable fortification. Adjustable fortification is similar to fortification, but it is titrated based upon the blood urea level. We know that blood urea is a surrogate marker for protein content in the body. So based upon the levels of blood urea, that is, which is considered as 10 to 16 milligram per deciliter, for appropriate fortification. To check one values, if it is less than 10 milligram per deciliter, then we can increase the fortification. If it is between 10 to 16 milligram per deciliter, then there is no need to change any fortification. And if it is more than 16 milligram per deciliter, then the fortification needs to be decreased in order to appropriately give fortification. So this is one protocol for adjustable fortification that has been widely used throughout the world. So here, what happens is, if the full strength fortification is 24 kilocalories or one sachet per 25 ml, if the baby's burn level is less than 10 milligram per deciliter or urea is less than 21, then we increase the fortification to full strength. That is, add protein supplements about 0.4 milligrams per 100 ml. Protein supplement is only added, or sometimes we can use super fortification, wherein we increase the fortification level to 1.5 sachet also. So with this adjustable fortification, studies have shown that there is a significant increase in the weight gain when compared to standard fortification. This is standard fortification and this is adjustable fortification, which is reflected in second and third week of the baby stay in the NICU. But there was no difference in the first week of NICU stay. So this is more practical. It is generally they used to check the burn value or urea values twice a week actually to titrate the human milk fortifiers. So it is practical, not labor intensive. Does not need expensive devices, and it titrates protein intake of each infant, and also it safeguards the baby against excessive protein. So as per the EMBA recommendation of 2020, adjustable fortification is considered as the best mode of fortification in babies. There is a third form of fortification, which is called as targeted fortification, wherein the milk is analyzed in breast milk analyzer, and we give extra protein or fat depending upon the. Here, it's good, but it is very labor intensive, and it is according to the population recommendation, but it will not be individualized. And in a recent randomized control trial, methanol didn't find any difference in the growth or nutrition in this group of preterm infants. So when to start fortification? There are only two randomized control trials that has been included in the recent meta-analysis. So in that one, Shah et al. Compared 20 fortification to start at 20 ml per kg versus 100 ml per kg. And Sullivan et al. Compared between 40 to 100 ml per kg. And they did not find any difference in the incidence of neck, feed intolerance, BPD, or sepsis. But there is one pre and post cohort study that has been done, which compared fortification at 50 to 80 milligram ml per kg to 100 to 120 ml per kg, and they did not find any difference in the outcome. So it is safe to start fortification earlier than what was initially proposed. As per the EMBA working group recommendation in 2020, fortification needs to be started at 50 to 80 ml per kg per day. So what are the problems that we face with fortification? So basically, delays gastric emptying and intestinal peristalsis. It can increase the risk of feed intolerance and neck, even though the studies have not shown that actually. There is always a risk of intestinal plug syndrome. And fourth is metabolic consequences at later age, which can happen because of faster increase in the weight gain of the child. So what is the Indian scenario for human milk fortification? So there is an online survey was done by Claire et al. In 2015, and they around 104 tertiary NICUs were evaluated. In that, 88% of the neonatologists were using the HMF in India. In that, 11% were starting for all babies who are less than 1.8 kgs. 32% started in babies only if they are less than 1.5 kgs. And 43% used NNF 2011 guidelines for fortification. It means that babies who are not gaining weight on full fortification, the baby was fortified. Reasons for not using in the 11% of and 12% of the patients who are not using, when they inquired, they found that because of risk of there was a fear of contamination and sepsis. There is a presumed high osmolarity in the HMF fortified milk. There is fear of feed intolerance and neck and the risk of additional cost. So these are some of the limitations of Indian available HMF. Most of HMFs that are ideal and available in the Western world are not available in India. We have only two to three HMFs that are available in India. That is a lactodose, hijam, and prenan HMF. And they are available only in major cities, and it is difficult to get human milk fortifiers in smaller cities and towns. On top of it, only lactodex HMF is studied in two randomized controlled trials, and are shown to be having significant weight gain, linear growth, and head circumference. On top of it, the cost. You can see that when you fortify lactodex HMF, the daily cost for a 300 ml of fill fortification comes to around 270 rupees. The hijam HMF, which is available online in some parts of Delhi and Goa, the cost is somewhere around 285 rupees. And the third HM human milk fortifier is 480. There is a prenan HMF, which is slightly expensive. It is 480 rupees actually. So for a daily labor who earns around 200 to 300 rupees, this might be a pretty expensive. And the Neolacta, the human milk derived fortifiers, cost around 3,000 to 4,000 rupees, which is quite expensive, which may be equivalent to the NICU charges for a day in a baby. Even though as Esprigan 2010 recommends human milk fortification is a standard of practice, but most Indian population who are economically disadvantaged are unaffordable to use it. So we had to look for cheaper alternatives for patients in low socioeconomic status and resource limited settings. So one way of doing it is fortify only when the baby is not gaining weight, which is as per NNF 20 recommendations, especially for low socioeconomic status and resource limited settings. Use MCT oil. When you are giving MCT oil, you are only giving calories, but no protein supplements will be given. But there is no much evidence for it. Third one is using formula. Formula is already an formula powder is also considered as a fortifier, and it is a cheaper alternative. Cost will be at least 20 to 30 times less than that of human milk fortifier. So the recommended intake of formula fortifiers, formula milk powder fortifiers is around 0.75 to 1 gram per 25 ml. Two main drawbacks of this one is small amounts. You have to take around 1 gram of fortifier powder for each 25 ml of milk, which may be difficult. You should have a scoop of 1 gram. And second thing is that in spite of fortification, still the baby will be deficient in some minerals and vitamins, which are not met even after fortification. So if you are using formula milk, which one to use? Is it better to use term formula or preterm formula? So studies have shown that preterm formula is better than term formula if you are using formula milk as fortifier. So it has better fatty acid profile, it has less lactose content, and higher concentration of vitamins and minerals. So if you are using formula milk powder as a fortifier, then use preterm formula than term formula. So here you can see that the estimated energy requirements for fortified, unfortified, and formula milk and fortified formula milk. The energy requirements is dealt with even with formula fortification. But with the plain breast milk, you are on 18. There will be around 18% deficit in energy requirements. Similarly, regarding the protein requirements, there will be a deficit of around 1.5 gram per kg per day of protein. And in formula fortification, they can be deficient up to 0.5 gram per kg per day of protein. So this is if human milk fortifier is available and there is no financial constraints, then even NRF 2020 recommends to start on fortification. So these are the various combination of fortifiers, that is lactodex, prenan, hijam, and preterm formula fortification. You can see that preterm human milk is deficient of most of the elements. The red is marked for deficient items. When you fortify with lactodex, you can see that it is only deficient in earlier lactodex was deficient in even in iron also, but now they have supplemented up to 2.4 milligram per kg per day of iron in the fortifier. And prenan is deficient in vitamin D. Hijam is deficient in zinc. And when you see preterm formula, it is deficient in protein, multiple vitamins, and also minerals. So to summarize this slide, preterm human milk is deficient in protein, calcium phosphate, vitamins, and minerals. Lactodex HMF is deficient in only zinc. Prenan HMF is deficient only in vitamin D. Hijam HMF is deficient in vitamin D and zinc. And preterm formula is deficient in multiple things. So in addition to this, there are some microminerals which has added in the human milk fortifier. So these are some of the guidelines for human milk fortification that has been given by various societies. So in WHO in 2011 gave a recommendation for low resource setting, wherein VLBW babies who less than 1.5 kg babies who fail to gain weight should be fortified. That was the guidelines. And the same was followed by NNF 2011 guidelines. But they used a gestation as well as weight criteria. Milan consensus in 2015 told that the babies with birth weight of less than 1.8 kgs will be beneficial for fortification. And they recommended standard fortification as ideal one. By the EMBA working group in 2019 recommended same, that is a birth weight of less than 1.8 kgs, and the starting point for fortification should be at EBM of 50 to 80 ml per kg. And NNF 2020 guidelines say that babies should be fortified if birth weight is less than 1.8 kgs and the volume reaches 50 to 80 ml per kg per day. But here there is a note saying that for resource limited settings who fail to gain weight despite of adequate milk feeding, they should be fortified. Fortification should not be a standard of practice in those settings. To summarize, preterm growth and velocity are associated with developmental outcomes. Human milk fortification is associated with better anthropometry indices. We have to follow the NNF 2020 guidelines, and we have lactodex HMF and prenan only in the market, and hijam, which is not freely available. If possible, adjustable fortification should be done, but we don't have in India. We don't have a specific protein supplements which can be used for preterm babies. So these are some of the recommendations that we can give today. One is start fortification at 50 to 80 ml per kg per day. Human milk fortification, that is lactodex or prenan HMF, can be used. One sachet to start with for next 48 hours, and then switch over to one sachet in 25 ml of breast milk. If you are using preterm formula, and especially in babies with financial issues, then you can go with 1 gram of preterm formula in 25 ml of milk. For this, you have to make customized 0.5 gram scoop. Whatever the studies that have been done, there are a few studies that have been done in preterm formula. They have used this 0.5 gram scoop to titrate the dose of preterm formula. And in resource limited setting, only 45 if there is baby is not gaining weight in spite of full feeds. Add vitamin D if the baby is on prenan HMF, and add additional supplements if the baby is on preterm formula. And fortification needs to be continued till 40 weeks of corrected gestational age. And in SBA babies, this has to be continued till 52 weeks of gestation. This is as per SPGAN 2006 guidelines, and this has not changed since then. And there is no new evidence to change this criteria. So in this index case, today the baby is around 25 days old, and you decide to add lactose HMF fortifier, one sachet in 25 ml. So the question here comes is it enough, or there is any need for an additional supplements? And if I decide to add preterm formula, then should we add any other additional supplements? So what supplements needs to be added in what quantities? That is what the next heading of talk is about mineral and vitamin supplementation in preterm neonate. So let's see about let's start about the iron, which is the most important iron, important micro mineral. So in a term baby, the total accretion of iron is around 75 milligram per kg body weight at the time. And predominantly this happens in the term during the third trimester, compared to preterm, which have relatively low iron stores, which is less than 25 milligram per kg. So if this term by up to 6 months is normal growth, usually they don't need any iron supplementation. But for a preterm baby with low iron stores, in addition to that, they'll have blood transfusion loss and rapid catch-up growth. The iron supplementation should be given as a prophylaxis, or else they may end up having long-term neurological disadvantage. So, we know that absorption coefficient of iron for a term neonate is around 10%, but the absorption coefficient or enteral absorption for a preterm neonate is around 20 to 27%. So we can't give the same recommendations as term neonates actually. It should be slightly. With the accretion of 0.37 milligram per kg per day, the recommended maintenance iron requirement for a child is around 1.4 to 2 milligram per kg per day, which is not available in the breast milk. In addition to that, there is blood loss and gain, which is not counted. With phlebotomy, babies can lose up to 6 milligram per kg of iron in 1 week, and with one blood transfusion, babies can gain around 8 milligram per kg. And with delayed cord clamping, the iron content can increase up to 14 milligram per kg. One important thing you should note about iron is there is no excretion pathway for the iron actually. So toxicity of iron is very common actually. So in order to check for that, various studies have been done on prophylactic interventions to see if what dose would be causing toxicity. They have compared 2 to 3 to 3 to 6, and they found that there is a increased incidence of higher oxidative stress levels and also infections. When you compare with 1 to 1.6 milligram per kg per day to 3, similar oxidative stress is increased. When you compare it to 2 to 4 milligram per kg, there was no significant difference. And babies, when compared to placebo, if you compare to 2 milligram per kg, at 6 months, most babies were anemic. So, so, so in baby with over supplementation of iron, you can end up having infection, poor growth, and free radical injury, which can happen if you give iron at around 5 to 6 milligram per kg per day. And deficiency is significantly associated with poor neurodevelopmental outcome. In order to titrate that, iron requirement for a child, serum ferritin levels is found to be very useful. And normal levels would be somewhere between 35 to 300 microliters per minute. And if it is less than that, we can increase the dose of iron by 1 to 2 milligram per kg. The only problem with serum ferritin is that it's an inflammatory marker and can be increased in case of sepsis. So when you are monitoring the iron contents in a baby, so check for both hemoglobin, reticulocyte count, and serum ferritin level, which gives a nice way to monitor the iron content in the baby to prevent toxicity. So there are some studies that has been done to check for early versus late supplementation. There is a four studies have been done with 246 subjects. There was no difference in the neck in these babies. And babies who are started on early supplementation showed better hemoglobin and ferritin levels and also had decreased blood transfusion. Whenever required for babies, very low birth weight babies, it is better to start iron at the earlier stage. So these are some of the various recommendations of prophylactic iron. The SPGAN recommends 2 to 3 milligram per kg per day at 2 to 6 weeks of gestation. Similarly, now the recent NNF guidelines recommends to start at around 2 to 4 weeks of gestation. The lesser the weight of the baby, go towards 2 milligram to start start at around 2 weeks of gestation. If the baby has a good weight, then go for around 4 weeks of gestation. The dose recommended is 2 to 4 milligram per kg per dose. This dose is found to be safe, but try to start the iron supplements at 2 milligram per kg and then increase slowly. And the duration of treatment for these babies should be at least 1 month. So when we so in comparison to estimated iron intakes in presence of breast milk, fortified milk, formula milk at daily intake of 180 ml per kg, you see that iron content in breast milk is very low, and this is a bar which shows that which is within the range. And fortification, most of the fortifiers have enough iron nowadays, and babies who are on fortifier do not need iron fortification. Third thing, babies who are formula fortified, the range is very wide. It ranges from 1 to 2.8 milligram per kg per day. So this may be slightly lower. So formula fortified babies may require some iron supplements. Formula fed babies do not require because most of the formulas are iron supplemented already. So available iron supplement, iron drops in India. That is one is most commonly used is tonopheron drops, and some of the other drops which contain 1 ml, which contains 10 mg of calcium iron supplements such as ferrikine, new hemo drops, and orofer drops. All these contain around 10 mg. So don't confuse with tonopheron and other drops. Do check for the concentration. So add iron if the baby is only on breast milk or if the baby is on formula powder fortified milk. Actually, there is no need for fortification in babies with human milk fortification, HMF fortification, and preterm formula babies. So titrate according to serum ferritin levels, hemoglobin, and reticulocyte count. So this is elemental iron, not calcium. In addition to that, you had to see that tonopheron and most of the iron drops have folic acid around 200 to 100 micrograms. Precautions: even though iron is added on empty stomach in pediatric and adult age group, you should not add that into the babies because of the osmolarity issues. So always mix with the milk and then give the iron supplements. On top of it, do not mix with other supplements. Don't give multivitamin and iron drops in the same. Do not mix the multivitamin and iron supplements in the same feed actually. So try to separate it. So these are the other micro mineral intake recommendations. So you can see this is based upon the accretion rate and absorption. SPGAN has given certain recommendation, and when we fortify the breast milk or when we give formula milk, most of them are sorted out. Zinc, copper, selenium, iodide, you will be given, and it is still unclear about manganese, chromium, and molybdenum. So, if the baby is on exclusively on breast milk, then this will be a concern to provide zinc, copper, and selenium and iodine, which has to be replaced with some multivitamin and mineral drops. So now coming to the calcium, phosphorus, and magnesium. So those are the micro minerals, and this is major minerals in the body. And here you can see that fetal accretion in third trimester for calcium is around 20 grams, and the phosphorus is around 10 grams, and magnesium is around 700 milligrams. So based upon this, the average accretion rate is so much, and the enteral absorption coefficient for calcium is around 40 to 70%. Based upon these three values, they form guidelines for requirement. The SPGAN had advised for calcium intake of around 120 to 140 milligram per kg. But SPGAN had overestimated the uh, enteral absorption coefficient of calcium, which is way below than what it was estimated by SPGAN, which is around 90%. And subsequent studies, especially some guidelines by AAP and College in 2014, the calcium and phosphorus requirements have changed and it is increased when compared to what we have seen in SPGAN guidelines. The main reason is because of differences in the enteral absorption coefficient in this. So based upon that, we can see that when you give only breast milk, there is a deficiency of both calcium and phosphorus. When you give fortified milk, you can adequately provide calcium and phosphorus. Formula fortification, yeah, definitely both calcium is less as well as phosphorus is less. And in formula fortification, you tend to provide adequate formula milk. When you give formula milk, you tend to give adequate phosphorus and calcium in these babies. So these are, so you have to add calcium and phosphorus supplements if the baby is on only breast milk or on formula fortified milk. The dosage is given here. It is 80 to 160 to 50 to 100 milligram per kg per day. And this has to be continued till the process of fortification, similar to 40 weeks of post-concept PCA, post-gestational age, corrected gestational age, or the baby is SGA at the time of discharge as a growth retardation at discharge, then you have to extend the fortification till 52 weeks of gestation. No need for additional calcium and phosphorus in HMF fortified milk or formula milk. Only two syrups are found to be good for preterm neonates. One is osteocalcium, which contains calcium of around 80 milligram per kg, and Osteopan-D, which contains calcium of 125 milligram. So in 5 ml. So it not only contains calcium and phosphorus, but you have to make a note that it contains vitamin D also. Other calcium syrups can be of higher concentration, which may contain 250 or 500 mg, not be used in neonates because they may end up in having necrotizing enterocolitis, and there is a strong evidence for it. And it should not be given in empty stomach, and it should be always given with milk. Try to give minimum quantity in many feeds. The best way to do is add 1 ml osteocalcium or Osteopan-D in each feed. That's the best way to add it. And do not mix it with other supplements. Like if you're adding multivitamin, then skip osteocalcium in that feed. So after knowing calcium and phosphorus, let's move on to the vitamin. Vitamin D, basically vitamin D reflects the maternal intake. As such, preterm babies or term babies, there is no difference in the vitamin D status or storage. And enteral absorption also is very similar to term babies. So, but we have to make sure, since it is a fat-soluble vitamin, we have to make sure that right balance between intoxication and deficiency. Dose more than 1,000 international units per day is not recommended by many bodies. It is not recommended by many bodies. So, effect of different doses of vitamin D supplementation of preterm neonates. Actually, we know for term neonates we give 400 international units. What should be the ideal dose for this one? Preterm neonates. So, in a randomized, in a meta-analysis of 12 studies, it has found that comparing 400 to 800 international units, there was no difference in the calcium, phosphorus, and vitamin D levels in both the groups. But high dose vitamin D supplementation had a better length, head circumference, and better immunoglobulin profile. So these are certain professional guidelines. Society guidelines for vitamin D. You can see the NNF recommends somewhere between 400 international units to 1,000 international units per day. A dose more than 1,000 international units per day, if you are giving for a child, then you are ending up vitamin D intoxication features, especially bone resorption. And it has to be given in preterm ELBW baby for at least 6 months. Following 6 months, you have to follow the term guidelines. So this is estimated vitamin D for fortified, unfortified, and formula milk. You see that breast milk, formula milk, as well as formula fortified milk are deficient in vitamin D. Only fortified milk has sufficient vitamin D status. So breast milk, fortified milk, and formula milk needs to be fortified. So vitamin D needs to be given in exclusively breastfed baby, formula fed baby, and formula fortified breast milk. And it can be given as a part of multivitamin supplements or calcium supplements. You should not be adding vitamin D separately, because if you are already giving calcium supplement, it also already has around 400 international units of vitamin D. And most of the multivitamins nowadays contain around 1 ml contains around 400 international units. So do not add it if it is already there. And be careful when you are using fortified HMF fortified milk. If you are adding vitamin D in that, then you are giving at least 1,700 to 1,800 international units of vitamin D, which can cause toxic, which can be toxic to the child. And this higher dose needs to be continued till 6 months, following which you have to switch over to the term guidelines. And titrate this vitamin D based upon the values of calcium, phosphorus, and alkaline phosphatase values and vitamin D levels. So these are some of summary of the other vitamins, especially fat-soluble vitamins can cause some serious, can prevent some serious morbidity and mortality. And water-soluble vitamins are all important, but they are not stored in the body, so the levels decline rapidly. So it has to be started from day one itself, either in the TPN in the form of multivitamin supplementation, or once the baby is on at least 100 ml per kg, immediately start on multivitamin supplements. Optimizing early vitamin intake for both ELBW and VLBW babies are very important. Breast milk per se will not meet all the requirements, and content is further depleted by pasteurization and freezing. If you are using donor milk, this should be kept in mind. Milk fortifier and preterm formula provide all vitamins. However, products vary, and further supplements may be required. Multivitamin preparations are selective and rarely contain all the vitamins. You see the content of each vitamin, you see that there is a lot of difference between each vitamin content. But try to prefer using a vitamin which has zinc components in it. So especially Vicinal Z or Zincovit, because most of the babies, zinc is required in all forms actually. In either it is, if you give fortification or whether you don't give fortification or give formula milk, it is always required. Hello? So try to see either use Vicinal Z or Zincovit. So recommendation of multivitamins. So it can be given for all types of milk, whether it is plain milk or fortified milk or preterm formula. It has to be started once the baby is tolerating at least 100 ml per kg per day of milk. And this is as per the AIMS 2019 guidelines. And I didn't get any other proper evidence for starting multivitamin fortification. And it has to be continued till the fortification time, that is 40 and 52 weeks of gestation. And or you can use 3 months of postnatal age as per zinc recommendation by IAP, Infant Feeding and Young Child Guidelines. So now coming back to the index case. So today the baby is around 45 days old and the baby is around 1.4 kgs. And the baby is already on 21 ml of donor milk every 2 hourly. There are no metabolic bone issues. You go to rounds and relief of 10 days, and the resident doctor has kept the baby on to these medicines. So, what are the problems that you see here? And you can send me a chat if I don't know. Sorry, I think I lost chat actually. Okay. Uh, so, what are the problems you can see, and what we can discuss without chatting? And here you can see that the baby is on multiple supplements. Actually, the baby is on HMF fortifier, the baby is on multivitamin fortifier, iron, vitamin D, and osteocalcium, 1 ml per feed. And you see that most of these fortifiers are not required. HMF, you know that already it provides iron supplements. So do not add iron supplements if the baby is already on fortifier. HMS already also provides calcium and phosphorus for the child. So no need to add separate osteocalcium syrup for the baby. And the baby is, in addition to that, you are giving vitamin D. So what happens is the baby is already getting around 600 to 800 international from the fortifier. On top of it, the calcium supplements is giving some 400 international units, and multivitamin is giving some 400 international units. So the baby can easily end up having vitamin D intoxication. And if you are adding this more than iron supplements extra, then you are more, the babies are more prone for oxidative stress, and you can end up in increasing the risk of ROP in these children. So uh, try to minimize the extra supplements that you are going to add. To summarize, supplements in hospital stay is the for breast milk fed baby, you have to give calcium phosphate, iron supplements, and multivitamin supplements. For babies who are fortified milk, just give multivitamin supplementation. Babies who are formula fortified, give calcium, iron, and multivitamins. And preterm formulas, just give multivitamin supplementation. In either of these, there is no need for adding separate vitamin D for the kids. Okay. So now the baby is corrected age is 35 weeks and 1.5 kg. Now you decide to discharge this child. You plot the baby onto the growth chart and you see that the baby has EUGR, extrauterine growth retardation, as per the Fenton tags. And then what would be your feeding advice for this child after that? And what supplement do you advise in this baby? So there is no recommendation for the feeding post-discharge guidelines after 2006. Most of them are following the same post-discharge guidelines since 2006 as provided by APSIGA. So there may be need for revision of these guidelines. For babies who are adequate for gestational age or AGA baby at discharge home. So what you do is put the baby onto the direct only breast milk. No need for adding fortifier for this children. And if the baby is grown adequately in the NICU, then just discharge the baby. If the baby is formula fed, then standard term formula is good enough with long chain polyunsaturated fatty. Baby is small for gestational age, as in our index case, then you have to start on human milk fortification. And it has to be continued up to 52 weeks of gestation. And on top of it, if the baby is, you are discharging the baby on enriched formula milk, then use enriched formula milk. Enriched formula milk can be either a post-discharge formula or a preterm formula in a neonate. So, regarding the human milk fortification in discharge patients, the main problem with that is it. One worry with most of the patient doctors is that once you discharge the patient on human milk fortification, it can affect the breastfeeding rates. That's what the problem is. But studies have shown that there is no deleterious effects on the breastfeeding for the child. So you can continue fortification as well as breast milk for the babies together actually. So you can do that in this one. So if the baby is discharged on formula feeds, which formula is better? Whether it is a standard formula or preterm formula or post-discharge formula. So among these three things, preterm formula is found to be better than post-discharge formula or standard term formula. The preterm formula that we routinely use one is a Prenan or Aptamil preterm or Similac Neosure. All these are lactodose low birth weight formula. All these formulas can be used at the time of discharge if the baby is small for gestation. So other supplementation is one is iron. This should be continued till 6 months. And following that, term nutrition guidelines has to be followed. So for preterm formula, preterm babies, it will be for 6 months you give the iron supplements, and followed by that, the iron supplement has to be continued for next 1.5 years as per infant and young feeding guidelines. And second thing is vitamin D to be started separately only after stopping multivitamins or calcium supplement, and it has to be continued till 1 year. Multivitamins can be stopped at the time when you are making a shift from fortification, and similarly calcium supplements also can be stopped once the baby is off for time.